Hello, everybody. Welcome back. We have the pleasure of having on with us Dr. John Costello. John, thank you for making the time to come on the podcast with us.
Of course, happy to do it.
You are coming to us from the Medical University of South Carolina at Charleston, South Carolina. And you are one of the unlucky ones who were assigned a year in review. We were talking to Phil Levy about this, and he said, at first I thought this was great, but then as I started, it's such a big, daunting task to just do this year in review. You're doing a year in review pediatric neonatal cardiac critical care. And so for the people at home who don't have the pleasure of being on and being here in the conference with us, what are some of the pearls, some of the highlights of this year that you're bringing up to the conference today?
Well, I'll tell you, I had the same response as Dr. Levy, same thoughts when it's a ginormous task to summarize a year of progress and research in 15 minutes. But the approach I took was to try and touch on some important topics that I thought weren't going to be covered in other parts of the meeting. And so in that light, there are a few things I was going to talk about. I'm going to talk about today. One of those are the new recommendations that have been released for centers that are performing pediatric cardiac surgery in the United States. This was a multi-societal, multidisciplinary effort that led to 3 peer-reviewed publications that came out last fall with these updated guidelines for surgical centers. And the rationale for this work, I think, was multifaceted. There are over 150 programs performing pediatric cardiac surgery in the United States. Many of them are in very close proximity to each other. There's a wide disparity or difference in outcomes, including operative mortality, when you look at these centers. And most recent guidelines in the United States, at least, were issued more than 2 decades ago in 2022. So it was certainly time for an update. And I think there were a couple key things with that. The writing committee's one of the biggest recommendations was that there become 2 tiers of centers. And I think neonatologists can relate to this because of the 3 levels of NICUs, right? Level 1, level 2, level 3. And you're not going to be doing ECMO, for example, in level 1 or level 2 NICU. Those cases get transferred. So in that light, we came up with a recommendation that there be essentially 2 tiers of programs. An essential program where patients can get high quality care for more straightforward problems close to home, and then comprehensive centers that are typically higher volume centers where the most complex cases, including open heart surgery for neonates, should be performed. It's one of the highlights. This document's over 100 pages long. It's got a lot of details, focusing on many different aspects of the heart center. But it's a document that's definitely worth reading.
But it is very interesting, right? I mean, this idea that maybe we need to start categorizing these patients a little bit more, and maybe that closure of a benign VSD is not the same as a repair, exactly,
Yep.
absolutely, of a more complex cardiac lesion. What do you think is going to be the impact of this guideline or this new recommendation on how babies are cared for? Do you think this is going to move the needle towards regionalization of care or maybe de-regionalization of care? What are your thoughts on that?
Yeah, it's a good point. Part of the strategy when we put this together was to acknowledge the realities of the healthcare system in the United States. It's not a single payer system like exists in other countries. And we certainly didn't want to create a structure that was overly regionalized that could limit access to care for patients and families. So in addition to the sort of 2 tiers of programs that I recommended, probably the most important thing is that there's a strong recommendation for formal collaboration between the comprehensive centers and the essential centers. So, in terms of impact down the road, we'll have to see where this goes. We're certainly hoping by talking about this project at this meeting and others to raise awareness. We are But some of the concepts that have been talked about in the future and would be a certification type process for centers. We hope that the information will help leaders within children's hospitals and the heart programs within them advocate for resources with their hospital administrators. But there's even a long-term vision that this document could be utilized by third-party payers to, which at the end of the day is going to maybe the biggest carrot.
Absolutely.
To facilitate the type of changes needed to optimize care for all patients.
That's amazing. That's amazing.
I'm curious, you're quite a prolific researcher as well. Obviously, that's one of your roles at MUSC. What do you think? We got a lot of trainees who listen. You've done this year in review of what's new in cardiac critical care. What do we have left to investigate? I sometimes feel like cardiology and congenital heart surgery, gosh, we've come such a long way. But what are the things we still haven't quite figured out?
Well, I think the variation in outcomes that exist among centers is certainly suggests that there's opportunity for improvement. I think the adaptation of evidence can be slow, and better once randomized trials are completed and high quality evidence is generated, dissemination of that practice, I think that's important. I think that we need to do a better job of risk adjustment, identifying appropriate patients for clinical trials to make sure they're effective. And one of the things I'm going to talk about tomorrow is some data that project I've been involved in looking at an adverse maternal-fetal environment and the impact that can have on outcomes in neonates with critical congenital heart disease. And if you think about all of our current risk adjustment models that we use today, they all talk about factors that are present after delivery, like genetic syndromes and non-cardiac abnormalities, and obviously the complexity of operation that's going to be performed. But those models don't fully only explain about a third of the variation in outcomes. So there's a lot of information that's not incorporated into those models. And I think some of that is not necessarily related to the baby after birth, but to the prenatal environment and some maternal risk factors that can impact clinical outcomes for these babies with complex congenital heart disease. So,
what are some of these prenatal?
What are the signals?
Give us one or two.
Yeah, so things. It's very interesting. The things like hypertensive disorders of pregnancy, so preeclampsia, gestational hypertension. The maternal obesity, things like that can all impact
controlling HbA1c and having better control of the glycemic process.
Yep, certain for sure. Gestational diabetes, all those things can have downstream effects on fetal development and growth. And I think I'm preaching to the talking to a neonatology audience. Many of them are. Many neonatologists are certainly familiar with that, but there's evolving data now that these factors can have important outcomes on neonates with congenital heart disease and fill the gap for some of that unexplained variation.
Yeah, and that talk will be tomorrow morning at 8:15. Adverse maternal-fetal environments, a key to understanding diverse outcomes in neonates with major congenital heart disease. John, thank you so much for making the time to come by the Incubator booth, and we wish you a good rest of your conference and continued success in your work.
Thank you very much.
Thank you.